Okay, I'm going to get started. So, hi everyone. I'm Zaina. I'm your co-host for this evening. Welcome to today's Study Hub session on SBAs in dermatology for finals, done by the lovely Luamar, who's going to be taking us through this session in an SBA format. But before we get started, I just wanted to say that if you're new to Study Hub or this is your first kind of Study Hub event, welcome to Study Hub. Study Hub is an awesome educational platform that goes to provide online lectures basically more or less every single day during the week. So be sure to follow us on Instagram and Twitter at StudyHubMed to find out what events are running through the week for snappy SBAs, which are really, really helpful, and also exam tips. So be sure to do that. Before we get started, a few housekeeping rules. This session will be recorded and will be available on the Study Hub site within about 10 days. And the session will be split into 3 parts with 2 5-minute breaks in between, where our friends at the BMA will be joining us and giving us some much needed information. So we're really looking forward to that. We have Tim from the BMA who's going to be joining us. Also, this session, because it's an SBA format, will consist of loads of polls that you guys can take part in and answer the questions. So you'll have around 40 seconds to answer those polls, and then we'll be able to carry on with the session. But it's a great way for you guys to get involved. So I'd really, really recommend that you take part in that. And also at the end of the session, I'll be providing the link. But if you're viewing this from the website, if you just scroll down, there's the feedback form. If you can fill that in, it will be really, really helpful for our awesome educators to know what to do in the future. And it also helps Study Hub to know what events you guys are interested in. So without further ado, I'm going to hand it over to Luamar, who's going to start this awesome session. So over to you.
Hi guys, thank you for joining. Today, I'm Luamar, to start off with. I'm a final year medical student at St. George's, and today I'm going to be talking to you guys through some dermatology SBAs, okay? So I know some of you guys have your exams coming up. This session is going to be really focused on questions, high yield topics, and in particular, in particular, we're going to be running through some dermatological emergencies, some dermatological malignancies, and to finish off with some skin infections and a few extra things like autoimmune conditions as well. It's going to be quite a fast-paced session just because there's a lot to get through. And I know you guys have your exams coming up, so you're really focused on kind of high yield topics. You don't want to focus on niche, nitty gritty things. You want the bigger picture, how to focus on exam technique, that sort of thing. So I am going to be focusing on that. And if it is too fast paced, just let me know in the comments and I'll try and slow down. But hopefully it's going to be really useful for you guys as well. If you have any questions, if you want me to clarify anything at any point, please just let me know. I'm happy to answer any questions throughout, especially in the breaks as well. So let's get started. So to start off with, some dermatological emergencies. SBA number 1. A 11-year-old boy develops a rash on his hands. The next day he's brought to surgery, by which time the rash has spread to the rest of his body. So this is the picture of his hands. What is the most likely diagnosis? Erythema chronic migrans, erythema nodosum, erythema multiforme, eczema herpeticum, or urticaria. I'll give you guys roughly 30 to 40 seconds to answer that, and then we'll go through the answer. Great. So most of you got the answer right. It is number 3, so erythema multiforme. Just quickly to go through the question, important things to pick up in this SBA is the timing of the rash. So it's come on suddenly on his hands in particular. This is a child, and then it's spread to the rest of the body. In terms of important features there, it's just the fact that it's on the hands and then it's on the rest of the body. So not really typical of urticaria, not really typical of eczema herpeticum either, which is quite localized to the places where eczema is, but could be 1, 2, or 3. So looking on the picture, can someone just quickly write on the chat what is the key thing that points to multiforme? Zaina, if you could just let me know if someone writes something, because I'm having trouble looking at it.
We have the fact it's a circular pattern.
Yeah, Yeah. Any keywords, buzzwords for this condition when you look at the rash?
Target lesion?
Exactly. So these targetoid lesions are exactly what give it away. So it's that central necrosis, the kind of edematous center with the clear outer area as well is what gives you that target lesion. So in terms of these two conditions, the first thing to say is they are quite similar in the fact that they're both type 4 hypersensitivity reactions. So they're both delayed hypersensitivity reactions, and they also both resolve by themselves. But erythema nodosum is essentially an inflammation of the subcutaneous fat. And in particular, it presents as these discrete bruise-like lesions, most commonly on the shins. Other important things to think about is the fact that it stays for about 1-2 weeks, and then it goes away and it doesn't leave any scars or any atrophy of the skin. Whereas with erythema multiforme, it's these targetoid lesions with the central necrosis and surrounding erythema, but also it presents mainly on the hands and feet before spreading to the torso and the trunk as well. So they have different distribution patterns. In terms of things that cause them, there's this good kind of mnemonic for erythema nodosum, which is nodosum. But the things to pay attention to are the drugs. Penicillin is a big cause of erythema nodosum. The oral contraceptive pill can do it as well. Very common in SBA land for that to come up. Pregnancy. But the key thing to keep in mind are chronic conditions that also present as erythema nodosum. So that's sarcoidosis, TB, Crohn's, UC, that sort of thing. Whereas with erythema multiforme, the most common thing typically that you'll get in questions is a herpes simplex virus infection, and then the presentation of the multiforme pattern. But drugs can cause it as well. And in particular, I've highlighted mycoplasma. So if you remember your RESP learning objectives and particular niche things, mycoplasma can cause an atypical pneumonia, which can present as erythema multiforme as well. Fine. So next, SBA. A 10-year-old boy is brought to A&E by his parents after the sudden appearance of a sore mouth, skin tenderness, and now widespread blistering. He has a fever of 39.1 and malaise. He has no past medical history except for amoxicillin use for UTI a week ago. He appears systematically unwell with a temperature of 39.1, a heart rate of 180, blood pressure of 100/52, respiratory rate of 21, and SATs of 98%. On examination, there are widespread erythematous bullae and vesicles covering most of his arms, legs, and part of his torso. The lesions are also present on the oral mucosa. Examination shows a positive Nikolsky sign. What is the most likely diagnosis? 1, staphylococcal scalded skin syndrome. 2, Stevens-Johnson syndrome. 3, toxic epidermal necrolysis. 4, necrotizing Fositis. Or 5, erythroderma. Oh, okay. So quite split, and it's split on the two which are really relevant to this SBA. So that's really good. So let's go through it. Here we have a child who is extremely unwell, okay? High temperature, high heart rate. They're borderline becoming hypotensive. They're really unwell. That doesn't point to anything because all of these conditions from 1 to 5 cause a very unwell child. So in terms of the examination, we have a widespread erythematous bullae and vesicles. So we can rule some things out. Erythroderma doesn't present like that. As we'll see later on, erythroderma is more just reddening and edematous skin, widespread, as opposed to vesicles and bullae. Necrotizing Fositis can present with these features, but it's more localized. And number 1, with staphylococcal scalded skin syndrome, that's just an infection with staphylococcus that causes blistering, widespread blistering. So again, not really relevant here. 2 and 3 present essentially exactly the same. So they affect the oral mucosa and they affect the skin. However, the difference between the two is the extent that they affect the body. So here we see that it's covering most of the arms, legs, and part of the torso. If you just think about that rationally, you don't have to come up with a number, but you'll know that maybe that's more than 50% of the body. And so the answer would be toxic epidermal necrolysis because of the extent, really. So as you can see here, both of these conditions essentially are the same condition, but on a spectrum. Stevens-Johnson syndrome, you can classify it as affecting less than 10% of the body. If 10 to 30% of the body is affected, then there's an overlap between Stevens-Johnson syndrome and toxic epidermal necrolysis. And if there's more than 30% of the body affected, then it's classified as toxic epidermal necrolysis. And what are these two conditions? Essentially, they're type 4 hypersensitivity reactions. They're T-cell mediated, and they occur with drug use in particular. Okay, and then there's a good mnemonic here for remembering the drugs that cause these two conditions. Never press skin as it can peel, and that's referring to Nikolsky sign, which we'll get into in a second. But if you guys can memorize these drugs, it would be really good, just because they love this stuff in exams. In terms of how this presents, it's a very unwell patient with flu-like symptoms, a fever, and a rash that is widespread. And depending on how widespread, you'll be able to know which condition it is. It presents with vesicles, reddening of the skin, macules, and a positive Nikolsky sign. So all that means is on touching of the skin and rubbing the skin, even very lightly, the skin will shed off. And that's because of just the inflammation that's being caused. In terms of how you would manage these conditions, you stop all of the medication, especially if you don't know what's causing it. Usually these patients are so unwell that they need ICU support. And in particular, what's relevant for exams is if there's any ocular involvement, you need an urgent ophthalmological referral. So again, just let me know if you guys want me to clarify anything on that. Fine. So SBA number 3. A 51-year-old farmer presents with a severely painful right leg wound. He accidentally impaled himself with a crowbar whilst moving hay 12 hours ago. The wound is 2 centimeters deep, which he covered with a towel. Although the wound has stopped bleeding over the last 6 hours, the pain has been increasing and is now severe. His past medical history includes type 2 diabetes and hypertension. On examination, his observations are a heart rate of 95, respiratory rate of 19, a blood pressure of 144/80, and a temperature of 38.8. There is a 2 centimeter wound on his lower leg. It is surrounded by erythema and swelling, and there is one blister with foul-smelling discharge. The wound is very tender. An emergency X-ray demonstrates air bubbles in the tissues. Swabs are taken and broad-spectrum antibiotics are started. What is the most likely organism to be isolated? 1. Staphylococcus epidermis. 2. Clostridium perfringens. 3. Staphylococcus aureus. 4. E. coli. Or 5. Strep. Oh, you guys are so good. Well done. So most of you got that right. It is Clostridium perfringens. So again, just going through this SBA, the things that stand out is that this person's a farmer, okay? So they're dealing with soil, they're dealing with plants, animals, that sort of thing. So you're thinking particular bacteria and organisms are causing this, okay? That's something that should just be kind of at the forefront of your mind. Because Clostridium perfringens is a typical organism for soil wound infection sort of things, especially when the vignette says something like a farmer, you should be thinking about Clostridium. Other important things are the type 2 diabetes. So type 2 diabetes is a risk factor for the condition we'll be talking about in a second. And other things is especially the foul smelling discharge. So that is key. Can anyone tell me what condition they're thinking about in the comments? Let me see if I can.
Someone's saying, is it gas gangrene?
Yeah, smashed it. So it is. It's gas gangrene. And what gives it away, obviously, is the gas in the X-ray. But this could also, if it didn't say X-ray demonstrating air bubbles, this could equally have been necrotizing fositis, where you would be split between Clostridium and strep. So if you voted on strep, that is a very good guess. Well done as well. But it's the X-ray that gives it away that this is gas gangrene. And this picture is very typical. So we'll just go through that in the next slide, what it looks like. So necrotizing fasciitis, it's this rapidly spreading infection in the fascial plane. Okay, and that's important to mention because these patients, they're extremely unwell, but they're in a lot of pain and you can't quite pinpoint why. So it's pain out of keeping with the physical findings. And the reason for that is there's an infection which is just kind of, brewing in the fascial plane, and it's not showing in the superficial skin. So when it does show in the superficial skin, that essentially means that it's widespread and it's quite severe already. There are 3 types of necrotizing fasciitis. The first is most common, and it's caused by a mixture of different bacteria, anaerobes and aerobes. Typically in a vignette, it will be post-surgery in a diabetic. Type 2 is most commonly caused by strep, pyogenes, and type 3 is gas gangrene. Okay, so gas gangrene is a type of necrotizing fasciitis caused by Clostridium. With necrotizing fasciitis, what you want to look out for in SBAs is the dishwater colored fluid. So if you look at the picture in the middle, you can see that kind of yellowy greenish fluid coming out of the wound. And you may also see some crepitus because there may be some gas in the subcutaneous tissue. And on X-ray, you'll see gas, and we'll see a picture of that soon. And in management, this is A to E approach. It's emergency, high mortality for this. So you want to treat it rapidly with a high dose of broad spectrum antibiotics and urgent surgical debridement. Fournier's gangrene is a type of necrotizing fasciitis that affects the groin. Okay, so typically this might be a rapidly spreading UTI, a perineal abscess, or if you've had surgery in the area and you've introduced some bacteria there, that's caused this. So like I was saying, the reason that these patients are severely unwell and in so much pain without you being able to pinpoint what's going on is because there's an infection in the fascial plane, and by the time it spreads to kind of the superficial subcutaneous tissue or skin even, so by the time you see the physical findings, it's probably spread to other parts of the body already. So gas gangrene, again, a type of necrotizing fasciitis. There are 2 types. There's wet and dry. So the picture at the top with the foot is wet gas gangrene, and this is just the necrotizing fasciitis infection spreading and causing inflammation, whereas the bottom picture is dry gas gangrene, which is ischemia, and you can see that because there's some dead tissue here of the toe. The thing to look out for in vignettes here again is there's going to be the findings of necrotizing fasciitis, so the crepitus and the foul-smelling discharge, but also there's going to be some gas on imaging, and when surgeons cut into the wound, there's going to be a release of gas as well. So as you can see on the X-ray, all of the gas here is just very clear to see as well. Fine. So SBA 4. This 8-year-old girl has a history of asthma and eczema, but is normally fit and well. Yesterday, she developed a rash on her face, which extends down to her chest. She feels unwell with a cough and runny nose. What is the cause of her symptoms? 1, Ramsay-Hunt syndrome. 2, impetigo. 3, staphylococcal scalded syndrome. 4, Guttate Psoriasis. Or 5, eczema herpeticum. Yeah, this is a easier question, but well done, guys, nonetheless. So this image is just so typical of eczema herpeticum. You have the vesicles with the erythematous base in an area that's typical of eczema, which is skin folds. And this child has a cough and a runny nose, suggesting that they have an infection. And as you guys, I'm sure, are familiar with, eczema herpeticum is the condition where you have a superimposed herpes simplex virus infection on top of an eczema area of the body. The reason I've put these three conditions on the same slide is not because they're caused by the same thing, they're not. So Ramsay-Hunt syndrome and herpes zoster ophthalmicus are types of shingles caused by varicella zoster virus. However, I always used to get these confused, like forever. I always used to get these confused. So just to separate them and have them clear in your mind what each one is. Starting off with eczema hepaticum. So typically it's going to be described in an SBA as a monomorphic vesicular lesion, meaning, as you can see in the picture, all of the vesicles are very similar. There's not changing shapes or colors. It's all very similar. And it's in a distribution of area affected by eczema. The vesicles eventually become hemorrhagic erosions, and they're very painful, very itchy. Management is IV acyclovir in hospital. Ramsay-Hunt syndrome is latent varicella zoster virus, which reactivates and affects the facial nerve. Okay, so typically in a vignette, there'll be a facial nerve palsy and a painful vesicular rash, typically in the ears or around the ears. But just beware of the places that the facial nerve supplies. The rash could be anywhere in those areas, really. And management includes oral acyclovir for 7 days with steroids as well for 5. Make sure you're always reading up on guidelines and don't go off what any lectures say when it comes to management, because NICE is always updating management, especially ironically around exam time. I don't know. So just read up on guidelines and make sure you have your management sorted as well. Herpes Osteophthalmicus is similar to Ramsay-Hunt syndrome, but instead of the facial nerve, it's the trigeminal nerve. And in particular, it's the ophthalmic division of the trigeminal nerve. So as you'll see in the picture just below it, the rash is in the ophthalmic division. And what I was about to ask, but it's on the slide. So the tip of the nose is Hutchinson's sign, which essentially just means if there's a rash on the tip of the nose, there may be some nasociliary involvement, which basically suggests that the infection may get to the eye and affect vision. It typically causes things like anterior uveitis. And so if you see Hutchinson's sign, you need an ophthalmology referral ASAP. Fine. So, SBA number 5. A 32-year-old man presents with a sudden onset rash. He is otherwise well in himself and has no relevant past medical history. You see from his notes that he has recent tonsillitis for which he received amoxicillin. On examination, there are multiple papules on his trunk and proximal extremities. There is a fine scale on several of these lesions. What is the most likely diagnosis? 1. Drug eruption. 2. Psoriasis rosea. 3. Erythroderma. 4. Guttate psoriasis. Or 5. Acute meningococcal rash. Oh, wow. Okay. Interesting. So most of you went for drug eruption. The correct answer is Guttate psoriasis. But I can see why you would have said drug eruption. So let's go through this. This is a sudden onset rash. The patient is well in himself with no relevant past medical history, which often is the case with guttate psoriasis. So just to remind you guys that guttate psoriasis doesn't necessarily mean that the patient has psoriasis, okay? The patient may never have had psoriasis and may not necessarily develop psoriasis after having guttate psoriasis. It's just a form of psoriasis that comes following a strep infection. So the clues here are essentially recent tonsillitis, and I guess the red herring here is the amoxicillin. But just be wary with SBAs for going for something that doesn't point to a definitive diagnosis. You know, a drug eruption, that's a bit of a wish-washy kind of diagnosis to go for, you know. So just try and think carefully when answering SBAs as to what they're trying to get at as well. In particular, with the image, you can see that it's a scaly lesion. This isn't very typical of drug eruptions. I don't know, I'm not a dermatologist, but I'm not aware of any drug eruptions that appear like this with scaly, kind of monomorphic papules throughout the body. And it says it in the question as well, so fine scale. So that should point towards psoriasis, and specifically Guttate psoriasis. So a bit about Guttate psoriasis. It is very serious, so you need to admit these patients and treat them ASAP. Usually they need some ICU admission, and you treat it with emollients and steroids. Most cases resolve after a few months. It happens following a streptococcal infection, so typically an upper respiratory tract infection, flu, cough, that sort of thing in a young adult. And then after 2-4 weeks, these lesions appear. They're small, 2 millimeters to 1 centimeter in diameter, and they're scaly and mainly confined to the chest, the torso, and the trunk. Okay. It can be painful, erythematous, and edematous as well. And the thing to look out for with Guttate psoriasis, as well as all of these skin conditions, so Stevens-Johnson syndrome, toxic epidermal necrolysis, all of these skin syndromes that affect the whole body, is for dehydration, okay? Because the skin is so inflamed and such a big part of the body is inflamed, these patients can lose a lot of fluid and become very dehydrated, and it can lead to heart failure, so high output heart failure in particular. So that's why they become extremely unwell and they need ICU management. Hopefully that makes some sense. And last SBA before our break, a 34-year-old man attends A&E with a severe rash that appeared the day before. On examination, there is widespread erythema affecting more than 90% of the body surface. Although the patient is warm to touch, he is shivering. The temperature is measured 36.5, heart rate is 102, and blood pressure is 90/52. What is the most likely underlying cause of the rash? 1, herpes simplex virus infection. 2, staphylococcal infection. 3, Stevens-Johnson syndrome. 4, erythema AB acne. Or 5, atopic dermatitis exacerbation. Oh, that is so interesting. Okay. Can someone tell me in the comments why you think it is staphylococcal infection? Just out of curiosity. To be fair, this is a harder question. It is a harder question. So the answer is atopic dermatitis exacerbation. And to have got that, you would have needed to know what's going on in this patient. Does anyone know what the underlying diagnosis is? Throw it in the chat. In the meantime, let's go through the question in case no one's sure. So this is a severe rash. The patient has widespread erythema. As you can see in this picture, the skin is incredibly inflamed. It's very red and there's kind of just sloughing off of the skin. And this is widespread, more than 90% of the body, okay? Although the patient is warm to touch, they're shivering. These things are pointing to a condition. Does anyone know? If no one said anything in the chat, it's called erythroderma, which we'll go through in a second. And it's an emergency condition. Because there's widespread erythema, these patients become dehydrated and they can go into heart failure. And the underlying cause of erythroderma most commonly is atopic dermatitis exacerbation, so eczema exacerbation. So as you can see, it is widespread, just redness and edema of the skin. And by definition, it has to be at least 90% of the body. The most common condition, reason, as I've said already, is atopic dermatitis, just an exacerbation. But commonly, I've seen this as well on placement. Lymphoma can cause this as well, and a few drugs. The skin appears inflamed, edematous, and scaly, and patients are very, very unwell. These patients need to be admitted, stop all of the drugs, give them emollients and wet wraps to maintain skin moisture, just trying to retain the fluids that the person has so they don't become dehydrated. So if you guys have any questions, put them in the chat. Those are the SBAs that we have before we go on to our second section. So thanks. Thanks, guys.